to the implementation track. We've had an amazing day so far. We've learned all about the basics of how to interpret visual fields, how to interpret OCTs. We've gone into two different surgical devices, the Hydrus and the Omni. We have just talked about what glaucoma looks like now versus in the future. And this lecture is no different. We're going to be hearing from one of my personal mentors, Tom Samuelson from the Minnesota Eye Consultants, talking about decision-making in glaucoma, new options for old problems. So I'm going to let Tom kick it off.
Well, good evening. My name is Tom Samuelson. I'm a glaucoma and anterior segment surgeon in Minneapolis, Minnesota. I do specialty glaucoma surgery, consultative glaucoma work, as well as cataract and some refractive. So I'm going to speak on some of the decision-making in glaucoma these days and how we have some new options either available now or soon to become available to try to implement towards some solutions for some old problems. These are my disclosures. I have the privilege of working with many of the companies that are involved in the glaucoma space, primarily on the surgical side, but also on the pharma side. I'm going to start out by talking about some of the recent trends in laser therapy for glaucoma in recent years. For a variety of reasons, laser has become elevated in our sequence for managing glaucoma, whether it be because of increased awareness on ocular surface disease, or the desire to simplify drop regimens to either less drops or no drops, or we're finally paying attention to some of the compliance concerns that we've had throughout my career. We are using laser earlier and more often in the management of glaucoma. And while SLT has always been a viable option for the initial therapy, I shouldn't say always, for at least many years, laser has been considered an option for the initial treatment. You wonder if it's time to make a recommendation for laser as initial treatment, and I'll explain why I might say that. So based on recent data in 2022, is it time for SLT to become the recommended initial treatment, not just an option for patients? Now, this is a complex flow chart. I don't want you to get bogged down at all. I just want to show you how much thought that the National Institute for Healthcare Excellence in the United Kingdom has spent on glaucoma management, because this is a flow chart with recommended guidelines, and I've taken just a portion of it, and I want you to notice at the top in the green, it basically takes patients with newly diagnosed chronic open-angle glaucoma and basically makes the recommendation for laser as the initial treatment. Basically, it says for patients newly diagnosed, offer 360-degree SLT as the initial treatment. Now, if you follow it down, it'll say, if for some reason SLT is not suitable, offer a generic prostaglandin analog, or offer a generic prostaglandin analog if the patient chooses not to have SLT, or offer a PGA if you're waiting for SLT and the pressure's higher than you want and the patient might not have it for a month or two, then you start treatment. But the point of this slide is to show that in the UK and in much of Europe, the European Glaucoma Society has adopted this. Laser is recommended as the initial treatment, not just offered. So that's a definite change in the management. And it's all, I shouldn't say it's all, but it's primarily based on the results of the LIGHT trial. And most in the audience, I'm sure, have heard about the LIGHT trial and are aware of it. So I'm not going to spend a lot of time on it, but it is worth pointing out that this was a massive trial. 1,600 or 16,379 patients were considered for the trial. Most were excluded, but 718 were randomized to receive either laser therapy in the form of SLT or eye drops. So patients newly diagnosed, randomized to SLT or eye drop therapy. And as I mentioned, a huge study. And here's what I love about this trial. Look at the follow-up. 97% of patients in the laser arm achieved 3-year follow-up, and 93% in the drop therapy arm achieved 3-year follow-up. So very good quality data here, probably the best ever, frankly, as it relates to laser. Now, one thing that is different about this population than what we might be used to in our clinical experience with SLT as this was very mild glaucoma. In fact, about 30% of patients in both arms had ocular hypertension. They didn't even have manifest visual field or optic nerve damage. So mild glaucoma, and you can see the mean visual field defect was -3 decibels, which coincidentally is about the same severity level as all the MIGS trials. All the major prospective randomized FDA clinical trials for MIGS were about this same level of glaucoma. So pretty mild disease. You can see the pressure was in the mid-20s to start. And some really key things. More than one laser was allowed. In fact, 25% of patients got more than one laser. That's important. And 78% of patients were medication-free throughout the 3 years. So they came in, they had laser, and about a quarter of them were relasered, and 78% were medication-free for the 3-year period. That's really powerful information. And you can see here, looking at the control of the disease, the doctors were very aggressive in making sure that target levels were met. And you can see that 91% and 93% of patients achieved pressure at target. More patients in the drop group progressed. And here's really the most striking data point in my mind, comparing drop therapy versus laser therapy. You can see the drop is on the left. 25 patients in the drop group went on to have cataract surgery. Half that number went on to have cataract surgery in the laser group. So is the obvious question, does drop therapy cause worsening of cataract? This study doesn't prove that, but these numbers are pretty impressive. And then if you look at the percentage of patients, the number of patients that went on to need trabeculectomy, 11 patients went on to have trabeculectomy in the eye drop group, none in the laser group. So really impressive. And then another paper that was in Lancet recently, and a word about Lancet, if you're not familiar with the prestige of this journal. In the US, we're very familiar with the New England Journal of Medicine. It goes to all of medicine, not just certain specialties. Lancet is like that for much of the rest of the world. It's considered a very difficult journal to be published in. And so when you see an article in Lancet, like the original LIGHT trial was, and like this trial was, it gets your attention. And what this trial, different than the LIGHT trial, this is looking at laser randomized against timolol in severe glaucoma. So not the mild glaucoma that was in the LIGHT trial, but this is severe glaucoma. 74% of patients in this trial had severe stage glaucoma, 24% moderate stage. And this is in sub-Sahara Africa. And laser did better than timolol, was superior to timolol, not just equivalent or not inferior. It was superior to timolol in the management of glaucoma in this severe patient population. So I mentioned at the outset that the cachet of laser as initial therapy has increased, and here's a reason why these trials. Now, I want to draw your attention to an ongoing trial called the COAST trial. Maybe you're familiar with it, but the COAST is an acronym for clarifying the optimal application of laser therapy. So if we're going to use laser earlier and more often in the management of glaucoma, we want to really be confident that the laser dose that we're delivering and the retreatment schedule makes sense. So this trial is looking at just those two things. So the study objective to compare the intraocular pressure lowering efficacy of standard energy SLT, the amounts of energy that we traditionally use, versus low dose energy. Some would believe that delivering low dose laser energy on a regular basis, kind of like a booster shot for COVID, to use a contemporary comparator, in vaccinations, you give a booster as the immunity wanes. And some believe that you might do better giving automatic treatments with SLT before your pressure control wanes. So that's what this study is looking at, and really a fascinating study. So one arm of the study is going to get annual laser, and the other is going to get PRN. So here's the design. It's a consecutive pair of prospective randomized clinical trials. This is sponsored by the National Eye Institute. The first randomization is standard energy versus low dose laser. And then at 1 year, the patients are re-randomized, and half are going to get PRN dosing of the laser like we're traditionally have done. So if the pressure control starts to be lost, then you hit them again with the laser. So as needed laser repeat dosing, whereas the other arm's going to get just automatic redosing. They come back, and even if their pressure is good, they're going to get dosed again, but with low energy. We believe SLT is very safe, but using lower energy would make it even safer. And one thing that I think is a sign of the times, if you go on the Coast website that describes the study, it talks about the impact of this trial, and it's worth paying attention to. I don't want to just read slides, but it's interesting verbiage. It basically says, if the Coast trial validates an SLT treatment strategy that extends the duration of medication-free disease control, we move one step closer to the possibility of drop-free lifetime for our patients. That's a lofty goal, but it's being talked about at the level of the National Eye Institute. As I mentioned, this being an NEI-sponsored trial. It goes on to say, delaying the need for medications by 3, 5, or 7 years not only confers all the benefits of medication freedom during this period, which will be all that many patients will need in their lifetimes, because this is an elderly group of patients, but it also allows time for the development of safer and more effective drugs dosed infrequently via sustained release delivery systems, as well as better surgical options for those patients whose lifetime expands or exceeds SLT responsiveness. So basically saying, can we keep patients off drops for their lifetime or majority of their life? Thus, a new treatment paradigm consisting of SLT, then sustained release medication, then surgery, could offer the majority of glaucoma patients the very real possibility of a drop-free lifetime of therapy. Again, I don't believe that this is achievable. I think eye drops are going to be around and always will be. We're going to have patients that need eye drop therapy, no matter how good our lasers are or our surgeries are, but interesting to hear it being talked about with that degree of commitment. So one other laser related topic I want to talk about is an evolving concept called DSLT, direct SLT. And what the direct means is that it's being applied directly to the surface of the eye, not through a gonioprism. So if you look on the far left, traditional treatment is medication. We know about compliance issues. We know about ocular surface issues. We've had SLT for a long time, and there's been a relatively slow adoption in the US. And there's a variety of reasons that might be the case, but a small percentage of our overall patients are getting laser as initial treatment. DSLT is one company's answer to this slow adoption. Can we make it more efficient? Can we make it more patient friendly? Will these measures help elevate SLT to a higher percentage of new starts? So let me tell you what DSLT is. So it's direct SLT. The patient sits comfortably at a machine like you see you there on the left. The provider sees an image of their anterior segment and the limbus, and then deploys the laser, and it goes directly to the surface of the eye, as opposed to our traditional delivery where it goes through a gonioprism. So on the graphic on the far left, you see DSLT coming basically straight to the limbus, whereas you see the SLT, the traditional SLT, delivered through a gonioprism, coming in off the gonioprism through the center of the cornea into the angle in an indirect fashion. So indirect through a gonioprism is the traditional, whereas direct straight on approach is DSLT. Many of the parameters of the lasers are almost identical. You can see the same wavelength, the same spot size, the same pulse duration, basically the same delivered energy. And so really interesting technology. Again, here's a view of the setup, and then here's a view of what the surgeon sees. The algorithm detects the limbal region. It generates a image guided delivery. Basically, you can see all the dots is going to be where the laser will be delivered when the surgeon gives the word. And here's a video that shows this process. You enter the patient's details, you pick which eye, you pick the 360 treatment, you turn on the image guided tracking device. It identifies the limbus. As you can see here, the surgeon will determine if that's the appropriate orientation, hits the button to deliver the laser, and in about 2 seconds, the entire treatment is done. And not currently available in the US. It is in trials, and I'll show you some of the data. Here's the proof of concept on the left, and then the first in human study on the right. And these were done in Europe. And some of the initial work, well, all the initial work has been done in Europe. I do serve on their advisory board, so I'll disclose that. Again, we're basically getting ready to present details to FDA, the details from the Glorious trial. And the Glorious trial is a prospective randomized comparison, 1-to-1 randomization of DSLT versus SLT, and we'll be presenting that information to FDA very soon. So hopefully we'll have better lasers to offer our patients with regard to laser trabeculoplasty, and that should make it more patient friendly because there's no contact lens required, no coupling agent required. You can easily do both eyes in the same setting without blurring their vision for the drive home, because you don't use any contact lens or coupling agent like we do with SLT. VLAs is another laser in development, and what this is an OCT guided femto laser trabeculostomy. You're familiar with Schlemm's canal surgery that we have to do in the operating, where we can put devices in Schlemm's canal, whether it be stents, or we can put a catheter in Schlemm's canal and dilate it. Well, now in a clinic setting, we can make openings in Schlemm's canal using a femto laser guided by OCT technology. And the ultimate goal would be to use the OCT imaging to identify collector channels and put our trabeculostomy right in line with a collector channel. So we can make a 500 micron by 200 micron channel through the inner wall of trabecular meshwork without ever entering the eye with any kind of a blade, never making an incision. We just use, very similar to the docking that you might do for intralase LASIK or for femto cataract surgery. We can do that with a femto laser that can make an opening in the inner wall of Schlemm's canal. And Dr. Nagy in Budapest, Hungary, has the early data, which shows a nice pressure reduction. And so on the left, you see mean drop in IOP over time, and in the right, you see medication reduction. And these are all early trials. The US FDA trial is just getting underway, or I shouldn't say the US trial. It's outside the US, although several of us are involved in going to other countries and doing this laser, and then presenting to the FDA when the time's right, when we've got the study completed. But very high success rate in the early proof of concept patients. And of course, we need longer term data. But here you can see the patency of these collectors 8 months later, and you can show that because we're using femtosecond laser, we're not really generating any surgical trauma or surgical inflammation. So we're hopeful that these these channels will stay open. So one of the premises for the talk was that we're getting away as much as possible, at least, from eye drop therapy. I personally don't think we'll ever leave eye drop therapy completely, but hopefully the days of prescribing medications to the point of surface toxicity are over. The days of 4 to 5 drop regimens are over, except for maybe very refractory cases. But for most cases, hopefully we can keep patients on 1 or 2 drops. And another way to achieve this is with the Durista, the bimatoprost SR, which is a sustained release bimatoprost. You can see it's delivered with the trocar system that you see at the bottom, a 28 gauge needle. And one of the reasons this is appealing is that if you look at the graphic on the left, you can see aqueous humor concentrations of bimatoprost and ciliary body concentrates of bimatoprost. You know, the tissues that we want the drug, you see the levels of bimatoprost in the target tissues are much higher with the injectable bimatoprost than they are with eye drop therapy. So we get high levels in the ciliary body and aqueous humor, but then look at the graphic on the right. We have low levels in the bulbar conjunctiva, below detectable levels in the eyelid margin. We know that topical prostaglandins causes the lid periorbital fat atrophy. And so if we can reduce how much of the prostaglandin is on the surface of the eye, we're not going to get the conjunctival hyperemia, the corneal surface toxicity, the periorbital fat atrophy, all the things we're used to seeing with topical prostaglandins. So this is another interesting technology. I find it useful for patients that are non-compliant. I find it useful for patients that live in a nursing home and their family gets charged, or they get charged each time a nurse has to go in and deliver medications. I find it useful for patients with ocular surface disease. We were part of the Artemis trial, which basically studied this. The arrow on the left, the blue arrow, shows the last dose of bimatoprost SR. And for those patients in the Artemis trial, 80% of patients were medication-free at 1 year. Now, keep in mind, those patients received 3 administrations of the bimatoprost sustained release. And right now, we've only got FDA approval to do 1. So that's the Apollo trial. But even with that, 36% of patients were medication-free 1 year after the injection. So I tell patients that, yes, we can only give 1 dose right now. Hopefully that will get better with further communication between Allergan and FDA. But it does give an opportunity to give patients a drug holiday for those that have had surface toxicity or need pressure control because of compliance reasons. This just shows us giving the bimatoprost SR. This is a video that Nate Radcliffe, a friend of mine and colleague, sent me, just showing, he's got a nice slit lamp camera showing delivery of the bimatoprost at the slit lamp. So a really elegant technique, very straightforward for patients. Patients don't have any trouble tolerating the procedure. In the Artemis trial, we gave 3 implants, and as I mentioned, we're currently only FDA approved for 1 implant. And part of the reason is these implants don't biodegrade maybe as quickly as we thought. They're not as absorbed as quickly as we thought. So you can, if you give 3, you can have 3 canisters sitting there that haven't absorbed yet. And we want to make sure that there's no consequence to the endothelium. So right now we're giving 1. And there's other technologies where the implants do biodegrade more completely, and they'll probably be approved before too long, and we can give more than 1 of those most likely. Another thing that I just presented, I throw this in here because I presented on this at the recent ASCRS meeting, just finished last weekend, and that's the multi-pressure dial system. I do consult with Belkin, but the multi-pressure dial system is comprised of airtight goggles attached to a negative pressure pump. You can lower pressure non-surgically and non-pharmacologically. It lowers pressure during evening hours. And it's really the first physics-based mechanism of action to treat glaucoma. Think of the atmosphere as constantly pushing down on the body. Every part of the body, every body cavity, every organ system is exposed to that pressure. So at sea level, that pressure is 760 millimeters of mercury. But when you go to levels like below sea level, you are underwater, you get 1,540 millimeters of mercury pushing down on your entire body, but that doesn't cause glaucoma because that pressure is distributed throughout the whole body. So the intraocular pressure relative to the cerebral spinal fluid and the CNS is unchanged. So if the pressure measures 20 at atmospheric pressure, but we go down underwater, it still measures 20 because the entire body is subjected to that pressure. Likewise, if you go to Denver and you're a mile in the air, the atmospheric pressure is less, but your intraocular pressure doesn't go down because the entire body is exposed to less atmospheric pressure. So that's the concept, that our ocular pressure relative to the atmosphere and relative to the rest of the body is pretty uniform, no matter what level we're at, in whether we're underwater, whether we're in a mile-high city. But if we can take and create a microenvironment with these goggles by reducing pressure only over the ocular environment, we demonstrated that we can lower pressure relative to atmosphere and relative to the rest of the body. And this concept has been used in medicine before. The iron lung for the polio epidemic was a very similar thought. You lower pressure in this cavity and it helps the lungs expand. We're lowering pressure around the eye, and it helps lower intraocular pressure relative to the rest of the body. And most importantly, relative to the retrolaminar space. And I'll show you more about that in just a second. Just a few words on this trial that we're presenting to FDA very soon as well. We've got a call with FDA coming up next Thursday, actually, to discuss this trial, among other things. And this was a multi-center, examiner-masked, randomized clinical trial. 64 patients were randomized to receive pressure, negative pressure in the goggle on one side and no negative pressure on the contralateral side. And patients wore the goggles overnight. So think of sleep apnea therapy, kind of a similar thing. You don't put a mask on like you do for sleep apnea, though. You put these goggles on to help lower eye pressure overnight. And here's the system. This is how we measured intraocular pressure while the goggles were being worn. We had a tonal pen cover over a port that allowed us to check pressure through the goggle while maintaining the seal. And we have validated this in the laboratory and published on it, and believe it reflects what the proper intraocular pressure is. So the primary endpoint was what % of patients achieved a 20% drop in pressure from baseline. And you can see baseline pressure was 19.4. And in the goggle side, it was reduced to 12.9, whereas in the control side, there was very little change, as expected. So 90% of patients in the study arm achieved the endpoint, only 3% in the control arm. 100% of study eyes receiving the negative pressure had some pressure reduction at every time point. And that pressure reduction in the study arm was greater than 30% in addition to existing therapy. This just shows the green line is the study endpoint. What % of patients achieve 20% reduction or more? The red line is any pressure reduction. So the red line is baseline. You can see every study eye, every blue dot is above the baseline, meaning some pressure reduction. So every patient got some pressure reduction at every time point, as you can see here. So really impressive. And the pressure reduction was independent of baseline IOP. So it didn't matter where you started, you got this pronounced pressure reduction. There was no adverse effects, and 91% of patients were able to complete the trial, which is consistent with a lot of drug trials. So the dropout rate was not much different than typical drug trials. So it's important to understand what we're talking about when we think of intraocular pressure. We're basically comparing it to atmospheric. So if atmospheric pressure is 760 at sea level, then the pressure inside the eye would be 776, or we basically zero out the atmosphere. We talk about a pressure of 16. So if we take a normal eye with a pressure of 16, that's what we measure across the cornea. The translaminar pressure difference relative to the CSF pressure is 4, because CSF pressure is around 12. So that's really the important pressure gradient there. Now, a patient with glaucoma whose pressure is 24 inside the eye, 24 relative to atmosphere across the cornea, has an increased CSF pressure gradient of 12. If we can lower that with pharmacologic therapy to 18 and 6, we've improved that pressure gradient. If we can lower it further with the goggles, now we can pretty much eliminate that retrolaminar pressure difference, which we believe improves axial plasmic flow, improves the survival of axons and ganglion cells, and is a really exciting option because, as I mentioned, we can lower pressure from 15 to 10 or 15 to 12. Doesn't matter the starting point. So for some of these patients that have low tension glaucoma or are getting worse despite controlled pressures, it's really a potential advantage. And we believe that retrolaminar pressure gradient is what really matters. And we've shown, Brian Schaefer has shown that the retroorbital space is not under the influence of the goggles, and therefore the CSF should not be. And Randy Carden and Bob Weiner have both showed improved blood flow hemodynamics at the optic nerve head, which would be consistent of improving this pressure gradient. So the multi-pressure dial, again, not FDA approved as of yet, but we're presenting the data to the FDA, and we're optimistic that it's going to be a nice option for some of our patients that are getting worse despite seemingly good pressure control. And think of it like nightly dialysis of the optic nerve, if you will. If we can lower pressure low enough that they get axonoplasmic flow, it might help with ganglion cell health. So I want to finish this talk on comments about incisional surgery. So we talked about lasers, we talked about sustained delivery drugs, we've talked about the goggles as being maybe an up-and-coming option, not currently FDA approved. What about incisional surgery? Well, the management of both cataract and glaucoma is the most common time that that we do surgery for glaucoma. Sure, we do standalone surgeries, but the most common is when we perform cataract surgery and the patient also happens to have glaucoma. Standalone surgery for glaucoma might happen when patients are getting worse despite medicines and lasers, when the pressure is unacceptably high despite medicines and lasers, and when patients are poorly compliant or intolerant of medications. When I started practice in 1991, we had basically 3 ways to lower pressure surgically. We could lower it with trabeculectomy, we could lower it with tube shunts, we could lower it with cyclophotocoagulation. Now in 2021, 2022, we've got an absolute plethora of options to surgically manage glaucoma. And I'm not going to talk about them all. I'm just going to give some personal biases. When I do cataract surgery and I'm performing glaucoma surgery, I tend to be a minimalist. I like the indwelling devices. I think they're the least tissue disruptive. So on the left, you're going to see iStent. On the right, you see Hydrus. Both indwelling devices in Schlemm's canal. You can see on the left, that's an 8mm stent. The Hydrus, now purchased by Alcon. It was Ivantis. Alcon has it now in their portfolio. And then on the left is the iStent from Glaukos. Both, I think, are terrific options for patients with glaucoma. I tend to use iStent for patients on the more mild end of the spectrum up to moderate, and I tend to use Hydrus really across the spectrum, but perhaps for those patients that have a little bit of worse glaucoma. I think it stands to reason with iStent, we're doing far less tissue disruption. We're hardly doing any. With Hydrus, we're doing very little tissue disruptive, but it's a bigger operation. So I like them both, and I use them both, and they're my go-to procedures. Now, one new option for those of us that like to minimize the tissue disruption is from New World Medical, the Streamline. Here you can see a little probe comes out, it goes into Schlemm's canal, it delivers viscoelastic in each direction. I've been using this a bit more just to get a feel for it. It doesn't have the clinical data, not even close to what iStent and Hydrus have, but it is a new option that we can now consider for patients that have mild to moderate glaucoma. And as you can see in some of the videos I'll show, here's an animation showing what happens. You take the probe, put it toward the canal, flush against the canal. It creates an otomy of about 120 microns, and it delivers viscoelastic into the canal. One of the difficult things with this procedure is you can't see the otomy as well as you can with, say, iStent, because you see the opening because the device maintains it. Here, it's a little bit more of a leap of faith that it's creating an otomy, unless you have a lot of pigment that you can see right through or you see the blood reflux. But that's still, it's new enough that we're still getting used to how to best utilize this technology. And hopefully New World will generate some data that we can then compare it to some of the other minimalist procedures. Here's a clinical example whereby the otomy is created with the Streamline device, and you can see reflux through some of the openings. This is a good example because it's the canal's filled with blood. You don't always have that visibility. On the left is a KDB, a Cahook dual blade. You can see doing a incisional goniotomy. Now this is definitely more tissue disruptive than the procedures that I was showing you. On the right is the Omni device, which is my go-to for standalone procedures. So I don't do as many with combined cataract surgeries and Omnis, but I like it for its comprehensive approach to the canal. It viscodilates, it helps open collector channels, and you can strip the inner wall of Schlemm's canal for up to 360 degrees. So it's my go-to standalone Schlemm's canal procedure. But in select patients, I tend to use them all. So a lot of options for our patients with glaucoma. One comment about incisional surgery to wrap up here. No matter what we do, there's going to be risk to our patients. And I'm all about risk mitigation, but no matter what we do, there's going to be risk. If we don't treat the glaucoma aggressively enough, the glaucoma disease risk may prevail. If we get too aggressive with our surgical procedures, then we're giving them more surgical risk. So glaucoma risk, as you know, in the purple, glaucoma risk can be mild, asymptomatic throughout the patient's lifetime, or it can be severe and blinding. We have to find out which patients are in which category and make sure we treat them appropriately. Glaucoma surgical risk can be something as insignificant as the risk of disappointment if it doesn't lower pressure adequately, or the risk can be catastrophic if they get a suprachoroidal hemorrhage or hypotenuse maculopathy. So glaucoma varies from asymptomatic to blinding, and our surgical procedures vary from basically no risk or minimal risk, like an SLT or a iStent, for example, and catastrophic risk if they get a suprachoroidal hemorrhage with a trabeculectomy. So we have to identify which patients have bad enough disease and which patients we can subject to the risk of our more aggressive surgeries. Because I believe trabs and tubes are still very relevant in glaucoma management. I did several of each today, in fact. And trabeculectomy, despite its flaws, is still the most highly efficacious procedure in my hands. It's my preferred approach for patients that are at the greatest risk of vision loss from glaucoma. I think a really high quality trabeculectomy is an extremely valuable tool for a consultative glaucoma specialist. Some of the younger glaucoma specialists don't like to do trabeculectomy, understandably so, but there are patients that need aggressive surgery, and I still use that strategy quite a bit. You can see on the left is the trabeculectomy, on the right is a tube shunt. I tend to use Barbelts and Ahmeds and the newer Ahmed, the ClearPath. I tend to use all three of those a fair amount. And my practice has countless patients. I see them all the time, patients with such complex eyes and complex disease that their eyes would have been lost for sure, if not for their tubes. So trabs and tubes, I think, are still very relevant. They're here to stay, but they're best reserved for patients with severe vision loss or in whom the safer options have failed. So I tend to be a MIGS surgeon primarily, but I still do lots of trabs and tubes because I see a lot of bad disease. And I think most comprehensive glaucoma, consultative glaucoma docs do as well. So really kind of a rapid tour through some of the newer emerging therapies, as well as some of the more traditional surgical therapies like trabs and tubes. I want to thank you for your attention. It's sometimes difficult when there's not a live audience, but pick and choose the portions that you want to pay attention to a little bit easier virtually. Thanks so much and have a terrific evening.